why don't you ride off into your talk, Anne, taking the reins
Yes.
For your care?
Sure. Thank you, Dr. Dury. So in the interest of time, I'm going to get started. As Dr. Dury said, this is an analogy of the horse and the stable and how it applies to myeloma. So we'll talk about the stable of treatment, finding your gait, and going the distance. So the stable of treatment is the treatment options, side effects, symptom management, and supportive care. So treatment goals. Our goals for myeloma therapies are rapid and effective disease control, durable disease control, improved overall survival. We want to minimize side effects, allow you to have a good quality of life. And of course, with our supportive treatment options, we want to prevent disease and treatment-related side effects while optimizing symptom management and still allowing a good quality of life. That's one of our major goals. And we always encourage you to discuss your goals and priorities with your team. So very busy slides, the stable of treatment options. Dr. Dury hit on some of these, just showing you the columns from the left, the proteasome inhibitors. We went to the monoclonal antibodies, then the IMiDs, steroids, alkylating agents, immunotherapy, some others that don't fit a definite category, and then the cellular therapy is all the way on the right. So just showing you the drugs used in frontline maintenance and relapse setting in these categories. Some of them are FDA approved, some of them are not actually. Belantamab is still on the list for immunotherapy that was pulled from the FDA. And then some of the notable side effects are listed on the bottom. So we are going to go into a little bit more detail with some of these categories, but this is just an overall of this treatment options that are available for all of our myeloma patients. Teclistamab and CAR T, we are going to have a special slide on bispecifics and CAR T therapy, so I'll talk about that again. So CAR T here, the new treatment approach, and I'm sure Dr. Usmani is going to talk about this a little bit. Basically, it's a specialized procedure. We select the appropriate patient. Patients are screened. They undergo a apheresis, so we collect their cells. We do some bridging and lymphodepletion chemotherapy. Those cells are sent to an outside lab for alteration to actually attack the specific myeloma cells. In that interim, because they're gone for a couple of weeks, we do some bridging therapy if necessary, and then once the cells come back, we do lymphodepletion chemotherapy before you get your cells back, and then the treatment is the cell reinfusion, and then we do a lot of post-treatment monitoring. We manage you for quite a while for side effects and for response to treatment. So some of the tips for CAR T, I mean, this is the big buzzword, right? Actually, on the right-hand side is showing you the patient's own T cells. So these are the T cells that we apherese or collect from you. They are sent to a lab for alteration, for personalization, you might want to say, to really target that BCMA on the myeloma cell. That cell there is the myeloma cell, and once we give you your cells back, hopefully we have more myeloma cell death. But asking for a referral to a CAR T cell specific center before relapse is a good idea. The insurance authorization is required, which can take a little bit longer. You must have sufficient blood counts and organ function to be eligible. Sometimes there's a wait, and you might need bridging therapy, kind of to give you some therapy to control the myeloma before the CAR T cells are ready for infusion. This, unfortunately, has a wait list, so there's only specific slots that we get per month. Once you are eligible and you have your apheresis and your cells are prepared, you're in the hospital for a short time. You need a caregiver and must stay within proximity of the CAR T cell therapy center for about a month. There's some requirements, no driving for 8 weeks, and some other requirements. It's a one and done procedure. So this is not a cyclic procedure as some of our other therapies are, but patients need ongoing monitoring, okay? So some patients may need transfusion support and other supportive care after the procedure. CRS and neurotoxicity or infection are some of the possible side effects. Bispecifics are another treatment that target BCMA. BCMA is a very specific target on that myeloma cell. As Dr. Dury said, it stands for B cell maturation antigen. So different bispecific antibodies have differences in efficacy and side effects. About very good response rates, about 7 in 10 patients responded. CRS is common, just as in the CAR T therapy. Some people have had skin and nail disorders. The only FDA-approved bispecific right now in May of 2023 is called Teclavi or teclistamab, is the first, but actually more are expected in the next year or two. This is an off-the-shelf treatment, which means that it's not personalized for you. The doctor can order it, and we don't have to wait to give you this treatment. The route of administration and dosing schedule will vary depending on the specific product. Teclistamab is a subcutaneous injection. Some of them are IV. CRS, again, neurotoxicity or infection are possible side effects. And if you look at the picture on the right, it's just showing you that the bispecific antibody in the middle there is just bringing your myeloma cell on the right in very close proximity to a T cell, which is a very important cell in your immune system. And that leads to cell death. So that's kind of an easy way to describe how bispecific antibodies work. Two little sort of edges to the molecule that bring two cells together. So again, CRS is a common but usually mild side effect for CAR T therapy and the bispecific antibody therapy. CRS can show up as fever, fatigue, headaches, some nausea, vomiting, shortness of breath, diarrhea, weakness, confusion, some low blood pressure. And CRS stands for cytokine release syndrome. Basically, it's sort of your immune system going into a little bit of an overdrive. And you can have some symptoms related to your immune system, sort of like getting hyper stimulated. Neurotoxicity is another side effect of CAR T and bispecifics. It's not common, but it can be very serious. Some of the side effects in this category are headaches, confusion, hallucinations. You can have weakness, nerve palsy, tremors, seizures, encephalopathy, which is altered brain function. So we really monitor you from a neuro perspective while you're getting these drugs, just to make sure that this side effect isn't, going to show up. Infection awareness and prevention is very important. So again, infection prevention tips, you want to maintain good personal hygiene, always wash your hands, avoid crowds, and avoid sick people. I always tell my patients on active therapy, pretend it's March 2020. And we all remember what happened in March 2020, right? COVID really reared its ugly head. I mean, we always wanted our patients to have good infection control awareness, but I think we have to really stress these infection prevention tips. Sometimes we have to institute growth factor support with injections to raise your white count, sometimes immunizations, but no live vaccines. And sometimes we give medications to help reduce the incidence of infections. COVID, the best way to prevent illness is to avoid being exposed to the virus. Again, staying away from sick people, using a mask when you're in crowded areas. Get the COVID vaccine and booster. We still recommend these vaccines for our patient population, even though they may be a little bit less effective in patients with compromised immune systems. We still are recommending them. Again, remember, it's March, make believe it's March 2020, wear that mask when you're in an area where there's a lot of people and there's a risk of spreading, respiratory diseases. Avoid crowds and sick people. When you're indoors, especially, I'm on the East Coast in the winter, everybody's indoors and there's a lot of crowds and sick people are just in close contact with each other. You want to avoid kind of that. And of course, washing your hands often. And then reporting fever to your healthcare team, anything above 100.4, shaking, chills even without a fever, dizziness, shortness of breath, difficulty breathing, low blood pressure. These can all be signs of infection. The compromised immune system that the patients can experience comes from the disease and from treatments. And infection is a very serious consequence for myeloma patients. We do have to be mindful of this, and patients need to know what to report, when, and why. Some infection guidelines, so the type of prophylaxis. So HSV and VZV, this is the shingles kind of prevention. We give the standard prophylaxis recommended for all patients with myeloma. You might be on a cyclovir or Valtrex. PJP is another bacterial infection, very noted with bispecific agents and CAR T therapy. We can give you some prophylaxis, some medication to reduce the incidence of this infection. Other bacterial and fungal infections can occur. We might also give you more medication, especially if your absolute neutrophil count, a special white cell count, is low. COVID-19, we can consider monoclonal antibody therapy for patients receiving bispecifics or CAR T therapy based on your institution-specific protocols. If you have low gamma globulin levels, which is common in myeloma patients, we might recommend IVIG infusions. GCSF is the shots, the Neupogen, Neulasta, Granix, Zarzio. These can be given to help maintain a sufficient white count to help you fight infection. So supportive care to address side effects. Don't change the horse midstream, right? It's important to stay on myeloma treatment to control myeloma cells and get the most from each treatment. Responses tend to deepen over time. Talk to your team if the side effects are becoming bothersome. Your team can help you, but only if they know. We're not mind readers, right? You have to communicate with us. So some of the side effects or issues are listed here in the columns, and on the row is some of the medications and stuff that we can do to offset this. So DVT and PE prevention, these are the clots that some of our treatments can increase the incidence of. We might recommend blood thinners, compression stockings, and some lifestyle options like stopping smoking, lose some weight, maintain activity. Bone health, we might recommend bone strengthening agents like Exgeva, Zometa, Pamidronate, calcium and vitamin D. Sometimes we also do physical therapy, increasing activity, keeping your kidneys healthy, staying well hydrated. Sometimes our patients are on dialysis for a short term. We recommend certain avoiding harmful medications and using dose reductions of other medications that are harmful to the kidneys. Again, I don't want to belabor this, but infection prevention, using antimicrobial prophylaxis, IVIG infusions, injections, masking up, hand washing, avoiding crowds, avoiding sick people, monitor for fever, and taking the appropriate COVID precautions. If you're a patient that has neuropathy, again, we sometimes, very tough to manage. Getting diabetes under control can help. Sometimes we have certain antidepressant medications or anti-neuroleptic medications that can help. Vitamins can sometimes help. Massage, acupuncture. There's a lot of anecdotal supportive care things that can help. GI symptoms can also occur. We can see nausea, vomiting, diarrhea, constipation. I think we can meet with our nutritional support people in the clinic, and the nurses and doctors can also help you with prescribing anti-nausea meds, medications to help your bowels. Making good dietary choices and avoiding certain foods can help. Maintaining an active lifestyle and staying well hydrated, also very important for GI. So the symptoms of myeloma, they're physical: fatigue, constipation, pain, neuropathy, sexual dysfunction. These are all physical, but we can also see psychological symptoms of myeloma, right? Some of our patients are depressed, some of them are anxious, some of them have insomnia or a lot of sleep disturbances, decreased cognitive function, that so-called chemo brain, right? Decreased role in social function. And of course, we can't not forget the financial burden, right? I always think that one of the side effects or toxicities of myeloma is the wallet, right? The financial burden or the financial toxicity is definitely something we need to address. Steroids. I'm sure you're, as patients and caregivers, you're all familiar with steroids, the good, the bad, and the ugly, right? Steroids are a backbone and work in combination to enhance myeloma therapy. So they work synergistically to increase the efficacy of a lot of our agents. I think managing steroid side effects is important. Have a consistent schedule. Some people, it's best to take it in the morning. Some people, it's best to take them at night, depending on when they get that sort of hyperactivity related to the steroids. Always take them with food. They can cause a lot of stomach upset. You can use over-the-counter or prescription medications to help with the abdominal discomfort. Medications to prevent shingles and other infections is important because steroids are also immunosuppressive. And the steroid side effects are on the right-hand side here. Basically, steroids affect every single part of your body. They can affect your mood, your sleep schedule, your vision. They can increase the risk of cataracts. They can make you sweaty and cause flushing. They can make your have an increased risk of infection. They can cause palpitations, increase your blood pressure. They can cause stomach bloating, hiccups, heartburn, ulcers, gas. They can make your muscles weak. They can make your muscles cramp. They can make you retain fluid and gain weight. They can make your hair thin and can cause some skin rashes, right? They can, again, fluid retention and increase blood pressure. If you're a diabetic, it's important to realize that steroids can increase your blood sugar level. So very important to note this. I mean, these drugs sound pretty interesting, right? These are not benign drugs. So even though they are not technically chemotherapy, we need to be aware of all the side effects of steroids. GI symptoms, diarrhea could be caused by medications. Constipation can be caused by medications. Again, avoiding caffeinated, carbonated, or heavily sugared beverages, taking anti-diarrhea medication if recommended. The brat diet, bananas, rice, applesauce, tea, and toast is sometimes recommended for the diarrhea. Constipation, increased fiber. Fruits, vegetables, high fiber, whole grain foods, and sometimes using Metamucil, Benefiber, those kinds of things can help. Always increase your fluid intake with both diarrhea and constipation. That can help with the GI function and helps kidney function. And also just tell us what's going on so we can make adjustments to your medications and help you control these side effects. Pain can significantly compromise your quality of life. Many sources of pain, including bone disease, neuropathy, sometimes medical procedures. We'd like to manage pain, but we like to prevent it whenever possible. So bone strengthening agents to strengthen your skeleton, medications to prevent shingles, sedation before procedures. Interventions depends on the source of the pain. We can give you analgesics for medications to control pain. Sometimes activity can control pain. Surgical intervention, if it's back pain, radiation therapy can help control pain. Complementary therapies, yoga, supplements, acupuncture. Again, let us know what you want to try. Usually these things can help. Scrambler therapy is using electrodes to manage pain. That can also help with neuropathy. It's very important. Again, those lines of communication need to be open. Tell your healthcare team about any new bone pain or any chronic pain that is not adequately controlled. Peripheral neuropathy. What is peripheral neuropathy? It's damage to your nerves. Tell us about numbness, tingling, any kind of pins and needles sensation, burning sensations, cold sensation, muscle weakness. Prevention and management. Velcade can be given subcutaneously. Now it's mostly given subcutaneously, which reduces the incidence of neuropathy. It can be given once a week, which further reduces the incidence of neuropathy. Massaging the area with cocoa butter can help. Sometimes B-complex vitamins, sometimes amino acids can help. Safe environment, making sure that you have a safe environment if you have neuropathy in your feet with rugs, shoes, and furnishings. If it worsens, your provider may change your dosing schedule, may change your treatment altogether, may prescribe oral or topical pain medication, and may suggest physical therapy. Fatigue, right? Look at the horse with the long face, fatigue, right? 98.8% of you will complain about fatigue. Fatigue is the most commonly reported symptom, and there's a variety of reasons for that. The sources may be anemia, pain, reduced activity, sleep schedule disturbances, treatment toxicity, bone marrow suppression. Anxiety can happen in over a third of our patients, depression in about a quarter. So I think that a lot of our patients do not share these symptoms with us, but it's important to talk to us about these symptoms that are not well controlled, or if you have any thoughts of self-harm, because help is available. We need to have you, live a good quality of life while undergoing treatment for your myeloma. Rest and relaxation contributes to good health. I think that's kind of a no-brainer, right? Adequate rest and sleep are essential to a healthy lifestyle. If we don't get good sleep, that really increases our risk of anxiety, weakened immune system, heart-related death, worsens pain, increased risk of falls. Things that can interfere with sleep are medications, psychological reasons, fear and anxiety, stress, and sometimes sleep apnea, heart issues. And again, pain can really interfere with our sleep schedule. Sleep hygiene is necessary for quality nighttime sleep and daytime alertness. Engage in exercise, but not too near bedtime. Increase daytime natural light exposure, avoid daytime napping, establish a good bedtime routine. Maybe you want to have a certain routine before you go to bed, a cup of warm milk or tea. Associate your bed only with sleep. Everybody has their tablets out, their cell phones and the TV, all of that is probably not good environment for sleep. Sometimes a sleep aid may be needed. What you want to avoid before bedtime is caffeine, nicotine. I hope you guys aren't smoking. Please stop the smoking. Alcohol and sugar is also good to avoid before bed. Large meals, and especially heavy meals, can interfere with your sleep. And again, computer screen time, and that includes your cell phones, your tablets, kind of cut that off a couple of hours before bed. That will lead to better sleep. And again, the financial burden, I always talk about this. Financial burden comes from a lot of different sources. Medical costs, right? Premiums, co-pays, travel expenses to get to the clinic, supplies, co-pays, prescriptions, loss of income. Maybe your treatment happens to need a lot of time off from work. The caregiver time off from work. Okay, so you and your caregiver are taking time off from work, which can lead to a financial burden. There is a lot of assistance that is available. There are funding programs, there are federal programs, there are pharmaceutical supports, nonprofit organizations. There's a list of websites here. I think you really need to reach out to your team. There are lots of resources available that we can tap into to get you help with some of these specific financial issues, maybe copays or prescription drug costs. Please reach out to us. Don't be a hero. If it's a burden, let us know. We can utilize our knowledge of all of these programs that are potentially you may be eligible for. Be an empowered patient, engage in your care, right? That's important. So you are central to the care team, okay, right? Be empowered, ask questions, learn more, participate in decisions. I mean, just being a part of this webinar is a plus for you. You can see the whole team there. You are in the middle there, you and your care partner. Then you have your primary care provider, you have your pharmacist, your hemonc, your myeloma specialist, your support network, family, friends, the allied health staff, the subspecialists. Everybody is a part of your team. Understand the role of each team member, who to contact for what. Participate in support networks. If you have a support group for myeloma, that's even virtual. I highly recommend that. It can help you and the caregivers with some psychological support. Knowledge is power. Again, the IMF has a lot of resources out there. There's a website listed here. We have videos, we have e-newsletters, we have booklets that can be ordered, so you get the actual hard copy. And there's also downloadable forms of these. You can see them on the left. Every single treatment option has a little patient pamphlet. There are also generalized pamphlets. I have a slew of them in my office about myeloma in general, treatment options, about stem cell transplants, about laboratory, how to read your labs, your myeloma specific labs. They have a lot of information for you. Healthful living, infection prevention, renal and bone health is really the goal that you can help us, help you. Again, we talked about maintaining good kidney health, okay? Managing the myeloma, keeping well hydrated, avoiding drugs that are harmful to your kidneys. Some of these drugs had to be dose adjusted because of your kidney function. Diabetes management. Remember, diabetes that is out of control can also hurt your kidneys, so you want to keep your diabetes under control. You want to protect your bones. Nutrition, calcium and vitamin D support, weight-bearing activity, walking is excellent. Bone strengthening agents from your primary care, from your myeloma specialist. Preventive health care. Health screenings, vaccinations, stop smoking, eat well, dental care. And just because you have myeloma doesn't mean you don't have to get your mammography, your colonoscopy, your PSA checks. We want you to continue to have all of these health screenings that are suitable for your gender and your age group, right? Try to maintain a healthy weight with good nutrition and activity and exercise. Manage stress. It's tough. You have a lot on your plate, but rest, relaxation, good sleep schedule, mental health, social engagement. Again, try to join a support group that can be helpful. Complementary therapies do have a role, and an ounce of prevention is worth a pound of cure. That is true, right? Keeping active, right? Movement therapies can reduce stress, promote sleep. Yoga, Pilates, they have both shown to improve sleep and sleep quality. They improve your mood. So definitely something that you might want to look into. Keep a log or journal of your activity. Notify us, your healthcare provider, about any sudden onset of pain, progressive weakness, headaches, blurred vision, numbness, tingling. We do want to know about these things. Dehydration is really not a good thing. That can lead to low blood pressure and falls. Please stay well hydrated. Of course, if you're undergoing dialysis or have some other issue like heart disease where you might be volume sensitive, you're going to listen to your other healthcare team members about your fluid restrictions, but in general, you want to stay well hydrated. Do not overdo it. Do not force exercise. If you're hurting, you want to stop, and also, don't try things without discussing it with us. We will let you know if it's a good idea or a bad idea. But in general, we want you to have a good quality of life. Myeloma bone disease may affect your ability to do certain movement activities. Again, check it out, review your activity interests with us, and we'll let you know if it's a good idea or not, okay? The Nurse Leadership Board is something that I am proud to be a member of. We are a professional partnership that includes oncology nurses throughout the country and throughout the world. And there's a myeloma university. So this is a comprehensive online educational program on myeloma. And you can actually visit the website, or there's the QR code here. I highly recommend. It's universitymyeloma.org. So it's something you might want to be interested in checking out. And I think that concludes my presentation. I'll open it up for questions and answers, but I'll leave Dr. Dury to control the questions and answers. Thank you so much.
Thank you so much, Anne, for that comprehensive review of what's really important for so many patients. So there are quite a few questions have been coming in. Well, I'll start with a simple one. Just so somebody says, well, CRS, oh gosh. So what exactly is CRS? So just cytokine release syndrome, right? You talked about it, but
right. It's just it's sort of the immune system going into overdrive. So it's kind of a stimulation that. The easiest way for me to say it is it's a stimulation of your immune system. I know Dr. Usmani is going to be talking about some of these therapies. He might touch on that as well. But it's sort of like it shows up. It could be a fever. I mean, I mentioned something about fever, hypotension, hypoxia. You might be a little short of breath. You might have low blood pressure. You might have a fever. It's just a sign that your immune system is responding to the treatment. So Is it a good thing? It could be a good thing, but sometimes it gets out of control and we need to quiet it down a little bit.
Right. So we talk about that fairly casually, but CRS is a really important collective name for side effects that we get with these immune therapies, particularly CAR T, but also with the bispecific therapies. So another one for you, this word, scrambler therapy. That sounds amazing.
Yeah, I don't know too much about it. It uses electrodes to kind of to block transmission of pain signals. So again, I'm not too familiar with it. I don't know a patient who's had it, but it's sort of like I get electrode therapy. I'm not, if anybody knows a little bit more about it, I'm willing to hear about it. But I've heard of it, but I don't know anybody who's actually had it, has used it.
Okay. All right. Any of you guys, do you guys, Asad or Rafat, do you use this type of therapy? No. Okay. No scrambling. There doesn't seem to be much scrambling going on. Okay. All right. Then the slides will be available. A second dose of Evusheld, should you take that? I think maybe we could talk a little bit. There was a broad question that came in about COVID, and you did talk a little bit about COVID, but maybe, I think that, by the way, the scrambler, I think it is a little bit like a TENS unit.
Yes, I was going to mention that.
I think it is like a TENS unit,
Yep. Yes, very, very similar.
So maybe, Saad and Rafat, maybe you could comment on how are you managing COVID day to day now? We were so obsessed with like keeping up with our vaccinations and masks and all kinds of different things. But how would you describe your day-to-day care related to COVID right now?
I mean, I think, the good news is that I think a lot of people are immunized, and the strain that we have right now is not very virulent. So I think, we are not seeing really the severe cases we saw in the early days of COVID-19. Patients are getting it, getting over it. I think, obviously we do recommend the immunization. I am in the habit of monitoring the antibody against COVID-19, so I can tell my patient if they have antibodies or not. I think it'll give me some level of comfort that if they have antibodies against the COVID-19. So I monitor that. If I start seeing that they are losing it, equivocal results are negative, I encourage them to get vaccinated. We have a lot of patients now who are being treated with anti-plasma cells directed therapy, whether, BCMA targeted therapy, CD38 targeted therapy, the daratumumab, the bispecific, the CAR T cells. All of these patients become, as you heard from hypogammaglobulinemic. They're normal IgG, and I always, calculate the normal IgG, because some of the IgG can be monoclonal protein. So you have to know which one is, what is your normal IgG? And if they're low, we're giving intravenous immunoglobulin. We supplement their immunity with normal immunoglobulin. And because the immunoglobulin is coming from normal, healthy, donors that have been around COVID-19 for the last couple of years, they do have antibodies against COVID-19. So I am totally impressed by the level of, protection that our patients have today, our ability to provide extra protections. I encourage vaccination. And again, the most important thing is that we always have to be careful. I mean, when I get on an airplane, when everybody's coming on an airplane, I have my mask on, and I probably won't take it off until somebody, I'm sitting to people around me who are not coughing, sneezing, and doing all that stuff. So it's very important that we are careful, but we're not going to live in a bubble. It's time to live your life.
Loosen up a little bit.
Yes.
There's some questions about vaccination and boosters, and maybe Anne or Sad. So, and I get this question all the time. Most of our patients, and I suspect most on this webinar, have had their vaccinations, and probably at least one of the what we call the bivalent boosters. But now patients are coming up to 4 to 6 months, and they are wanting to know, well, should they be getting another booster, perhaps? I don't know if either one of you would want to comment on that.
No, I can begin. So, every institution has different policies, but we are proposing our patients to proceed with, getting that booster, just as, Rafat very eloquently made the case of, how safe it's become, where we've gone from, pandemic to maybe, endemic, COVID infection in certain areas. I do feel we cannot let our guard down from a vaccination standpoint. Right. So we are proposing, we are, recommending our patients to get it.
Right. And what's your policy in Hackensack?
We are also recommending that they get it. Absolutely.
Yeah, in that 4 to 6 month time frame. Right. All right. And so are patients wearing a mask when they come into the center? Do they have to for your centers? Or no?
Yeah, I mean, in our transplant unit, in our cancer, the hospitals is not mandating masks, but in oncology areas, we're still doing masks.
And same here. So actually, the guidelines are a little bit less restrictive for the solid malignancies, but for the blood cancers, it's still highly required in the transplant units and the leukemia, lymphoma, myeloma world.
Yeah, I agree with that. That's exactly what we're doing. I think the policy is more lax for solid oncology patients. Mm-hmm. And then, even on the physician side, in the ambulatory setting, we're not letting our guard down.
Mm-hmm.
Right. So I certainly agree with that. And there's some questions along that line here.
Brian, there's somebody asked a question. He had a stem cell transplant, and he said, does he not have any immunity. I mean, I think the way I describe it to my patient is that
Right.
after stem cell transplant, you have
answer that one, yeah.
immunity. So,
Right.
but you need to get re-immunized, just to boost your immunity against things. And we start that 6 months out.
Right, exactly. This question about DEX. For DEX, it's important that 1 day a week on the DEX is most important. It's good to have time off of the DEX. Just seeing if there's anything else that we could easily cover here. The slides will be available, and we're obviously just halfway through the webinar, so we both Rafat and Saad will be talking after we take a short break here. And Denise is letting you know that the copay with LLS is open again, which is good to know, right?
I just saw that email. I just got an email today. So the LLS is now the copay, because sometimes I guess the funds run out or whatever, but now it's open again for myeloma. Yeah, I just got the email today, this afternoon. So that's good news. Again, patients should always look for help with the healthcare team about tapping into these resources.
Right. So I think that we've covered, because some of these we're going to touch on later, the bispecific and the CAR T, we're going to be going over quite a bit in a little bit here. All right. Well, there was one question here about the MGUS-like phenotype. Yeah. So this is a little bit confusing in the sense that this MGUS, the monoclonal gammopathy of undetermined significance, which is a very, very early precursor of myeloma, is MGUS. But this whole thing is about patients with myeloma who've actually gone through therapy. So patients have gone through treatment for myeloma, and then they're stable. And then it kind of looks like an MGUS again. So it's kind of like a secondary MGUS where after going through all the treatment, maybe a transplant, all kinds of things, their levels are low and stable. And this is what we call MGUS-like. And so what the Spanish group were able to show is that it's possible to identify patients who are MGUS-like, which is very helpful, because they're stable and they don't need to have any treatment, and one can safely monitor them possibly for quite a number of years. So this is a category of patients who have actually had myeloma but are now being followed after treatment.